What I'm saying is the reality is children from a younger and younger age are being exposed to concepts that they do not have the psychological, emotional, or cognitive capacity to handle properly.
So I've brought up the idea before about, and I'm hesitating to say this because I can see how it would be potentially taken out of context, but I'll say it anyways. This focus, this hyper focus on my identity is my gender and focusing solely on that. From what I've read, and I haven't done a ton of reading admittedly, but this isn't as clear a phenomenon or as prevalent in other cultures where there are, let's say, more social struggles, financial struggles, and so on and so forth. So I wonder, is there some element of this rapid onset gender dysphoria and hyper focus on gender as my identity? Is there some element of it that has to do with in North American culture, there's, not a whole lot that is otherwise distressing, and this is something that individuals may be latching onto?
Yes, now by saying that, people say, well, what about the climate? What about the, kids are afraid that they can't afford homes and everything. Yes, that is a big issue, but that's kind of let's say, a global issue.
Right.
It's kind of abstract, right? But as far as the immediate, yes, if your immediate issue is I need to eat,
Hmm.
or I'm trying to get to school through a war zone or
Yeah.
something, that's immediate in your face, right? So yes, so we know that this is more, statistically speaking, more among more affluent people, and B, the statistics are really clear more recently when you look at the people's either political identities or the identities of their parents, okay, or the families. They do seem to be more liberal, left, a democratic, right? That's so. Is it somehow that this gender related issue only affects those people? No. Okay. So again, there's something else going on. Now, having
Yeah.
said that, the rational, credible argument would also be, well, maybe a whole bunch of people on the right or whose families are on the right, they have the same underlying issues, but because of their
Hmm.
family structure, because of the politics, they can't come out. So that would be true for some people. I guarantee you, right? Among, let's say, the more right leaning or conservative families, there's a huge proportion or a certain proportion of people who cannot come out, whether it's as trans, gay, or what have you.
Sure.
But by the same token, right, there are many people on the left who, again, but through their behaviors, through everything else, they don't seem to be really like who they claim to be. But they're claiming to be this because that is the acceptable or the expected identity. Let's say non traditional. Okay, whether it's trans, whether it's non-binary, whether it's gay, whether it's pansexual, all these different identities. And am I conflating gender with sexuality? No, I am throwing them all together because for a young person who hasn't experienced, sexual behaviors, it's all abstract. For them, they are just it's one or the other. A lot of times they will say like I am like we're having like 5, 8, 10-year-old kids actually saying I am pansexual. You don't even know what that
No,
means.
no.
You're not even sexual right now. How can you say you're pansexual? Because it's an identity that they saw. And again, I'm not saying all children, even if it's one child, and it's more than one, okay, who say this, whether it's bisexual, pansexual, whatever it is, if it's not truly who you are and what you do, then we must question why are you grabbing onto this identity. And once again, for any because I hate to keep saying these caveats, but I know people want to take it out of
Yeah.
context. I am not saying that anyone who identifies as bisexual, pansexual, etc., is not that. I'm not saying that, but I'm saying there are a number of people who say that they are, or say that they're queer, and nothing about them would indicate traditionally that they are queer or pansexual or whatever. So, and by the way, in case anyone's wondering, pansexual is somebody who either does not see the gender binary, so they don't see it as male and female, they believe it's a spectrum, or they say, I'm into males, I'm into females, I'm into trans people, or non-binary people, or they say, I see the binary, but I don't care. I'm into the person. So whether the person happens to be a biological male or female, or if they dress a certain way, or if they identify this way, to me, that's not so relevant. To me, it's who the human is underneath. Okay, that would be pansexual, because we will be using that term over and over. So I just want people to understand. And again, never in the history. We never saw 5 or 8 or 10-year-old children before when people say, well, who are you? Well, I am Bobby and I am heterosexual. Blah, blah. They didn't say that.
Mm-hmm.
So these concepts are being, let's say, thrust onto children at earlier ages than they can understand. And I'm not claiming, like people who are too extreme, I'm not claiming that everybody's trying to groom these children and trying to make them into these, either trans kids or into gay kids or pansexual kids or whatever you want to call it. Okay, I'm not saying that everyone is doing that. What I'm saying is the reality is children from a younger and younger age are being exposed to concepts that they do not have the psychological, emotional, or cognitive capacity to handle properly.
Yeah, yeah. And I want to tie this all back to, again, as clinicians, and I'm not just speaking to fellow clinicians here, but it's also to parents who may be wanting to have their child evaluated or have things looked into a little bit further. Um, and gosh, I don't even know where specifically to start with this because I have so many different thoughts as far as what the implications of all of this are. I guess what I can do is I can start by pulling some more of Littman's data here. So back to what you were saying, as far as for lack of a better way of putting it, sometimes it seems like clinicians are going in with a preconceived notion, perhaps an agenda, perhaps incompetency, or all of the above. Um, but Littman's study found that 58% of the individuals that she interviewed that detransitioned um, felt that their dysphoria was caused actually, in fact, by trauma or another unrelated mental health disorder. And 50+% of those individuals also felt that their evaluation was insufficient. So this isn't just something that we're saying. This is, again, supported by data. This is just one piece of research, but I'm certain that there's others that show similar findings. So I want to talk a little bit more about our responsibility as clinicians and, what it should look like versus the fear that's been instilled by things like Bill C4 and whether we can or cannot ask or say or whatever the case may be. Um, I want to draw it back to, the fact that we have tools, we have things that we use, and um, properly trained, qualified clinicians use the DSM-5. We're currently in the text revision of it, and there's guidance that's utilized for all different types of disorders, including gender dysphoria. One of the things that clinicians do is that we are to look at what are the differential diagnoses, meaning what could be another possible explanation for what the individual is experiencing. And there's a whole list of differential diagnoses that we are to consider or at least, keep in the back of our mind when evaluating someone for gender dysphoria disorder. Um, so I suppose what my challenge is here is that how do we as clinicians navigate all of this where we're doing what we know is a best practice approach, which is, thoroughly evaluate, thoroughly investigating, considering other options. But then we have this political narrative being pushed on us as well.
Yeah. So what are we supposed to do? So here's the tricky thing. I alluded to it earlier. So let's say I've worked with many people with ADHD, with autism, neurodivergence. And so if they come to me and they say, well, I want to get an official diagnosis, I say, technically, I can do it as a registered psychologist. I can use the tools that we have to go through the symptoms, go through your life history, and arrive at a diagnosis. I can do that, and I do that. But when it comes to something like, let's say, ADHD versus autism, I say, as much experience as I have clinically, I'm not an expert in that.
Right.
So I always defer, and I say, let's go to other clinics, go to other doctors who have more tools, who use, for example, brain imaging, or who just, again, having worked with so many people, they can see things that if I looked at it, I wouldn't have the wealth of experience they have to say, you know what, even though it's not on paper, in my clinical experience, this is what it looks more like, A versus B, right? So the ethical person, the ethical clinician knows his or her limitations. And if they have issues or questions about the ability to distinguish between this potential diagnosis or that one, they will refer someone to someone who has better knowledge, right? So that's what we should be doing if we don't have. And I'd say when it comes to gender related issues, especially since the children or teens that's what we're talking about today, not so much adults, okay? But they are coming in with an agenda, many of them. Like, no, I want confirmation. I want to be affirmed. And if we're saying, well, I'm not really sure if that's what it is, because look at all these other issues that could help explain how you're feeling. Once again, that could, in theory, be a contravention of Bill C4. So because they don't want to risk it, again, they're stepping back and they're going, send them to the experts. And most of the experts have a particular perspective on all of this. And their perspective is affirm, affirm, affirm. How dare you say this is a disorder? How dare you question their lived experience? They are just being their true, authentic self. Let's affirm. Now, they can go through the steps, you would hope, which many, and we've seen many cases where they haven't gone through a thorough assessment, a 1-hour evaluation. That's nothing.
No.
For something as complex as this,
Yeah.
for people who are presenting with so many other issues, 1 hour is by definition insufficient, right?
Yeah.
Even one session would be insufficient unless it's like an all-day assessment. So the point is, even if they do all the steps properly, because there's so much gray, because it's so easy to interpret a behavior or an experience or a feeling as this way versus that way, so easy to do that, they can consciously or unconsciously not be doing the most thorough, competent and ethical job, right? And I would say that if you're in the field, and I've spoken to people and I've had communication with people in the field who are on that side, which is affirm, affirm, affirm. Once again, cognitive dissonance. If they were to step back and say, you know what, maybe in 5%, maybe in 50% of the cases or more, I was wrong.
Yeah.
How could they live with themselves?
Yeah.
They are not going to be able to step back and reflect and go, maybe I need to adjust my practice. So again, I'm not denigrating or making any claims against any individuals, but I am saying I have no doubt, having spoken to so many people, that there are many who are doing a bad job of properly evaluating people in these gray areas. And again, technically on paper, they may be correct because these symptoms match up. But someone who is less ideologically possessed could say, yes, but it also could reflect this.
Well, that's
and this makes more sense.
Yeah. The DSM's not a checklist, right? And that's why I preface for our listeners with, it is for a trained, qualified individual to look at, because no offense, but a layperson can look at the DSM criteria and say, oh, well, I meet all of that. But there's so much more robustness to actually meeting that criteria.
Right. And by the way, forget a layperson. How about this famous phenomenon, right? Psych students, when they go into abnormal psych or psych disorders, by the end of the term, they've diagnosed themselves and their family with like 100 different disorders,
everything,
right?
yeah.
Because they say, yeah, exactly. Because once again, you see a sign or a symptom, whatever, you may have that. But the question is does it meet criteria? Can it be ruled out by other,
and I'll add,
explanations?
with clinical significance. I think that's the biggest piece here, is that, and again, even with gender dysphoria disorder, the DSM says, these criteria must be met with marked clinical significant disruption in one's functioning. So, an untrained professional or somebody who doesn't do an evaluation isn't going to be able to discern and determine what is clinically significant.
Right. And by the way, we're going to keep going back to this just because I think it's something that people can appreciate. And if they can't wrap their head around the whole gender issue, when we come to like talking about diagnosing and so on, the ADHD one, I think people can intuitively understand better.
Yeah.
And, and I've seen so many cases where like with ADHD, they will give this questionnaire to, let's say, usually two different people. So it can be two different parents.
Yeah.
It can be a teacher and a parent, right? And when you look at it, again, it's the same child, sometimes in different settings, like at school versus at home, sometimes two different people, two different parents seeing the exact same behaviors. And, again, one parent might say, or one individual might say it's clinically significant, like it's extreme or something. And another might go, no, it's not. Or one, parent will attribute a behavior to this and another will attribute to that, right? So the fact is, as you say, we need trained people who are not just checking it off, but they understand, what does this really mean? And I'm just so concerned over the years from what I've seen that so many people, either it's because of their ideology or philosophy or their fear of being seen as, once again, breaking the rules or just not being a virtuous person, they are not doing their due diligence.
Yeah.
They are doing right? They don't fully understand. And again, anyone who does not agree with what we're saying, you need to talk with enough of these people,
Yeah.
or their colleagues, because again, I've spoken with so many people, and I want to say it over and over, whether it's the patient, whether it's the family member, or whether it's a clinician. I've spoken and read the writings of them, and I've seen the bias on all sides. And you and I are trying to speak about this in a nuanced and unbiased
Yes.
manner, and I
Yes.
hope people can feel that.
I hope so. And so on that note, another very controversial aspect of this discussion is the concept of clinicians taking a watchful waiting approach. Another interesting piece of data from Littman's second study was that 61 to 98% of those who were experiencing um, distress and gender dysphoric distress were okay if that approach was taken. And what I mean by okay is they may have ended up uh, learning that they are homosexual, for example, or this, again, this significant distress was dispelled once they went through puberty or once they went through the typical developmental stages that are complicated and distressing.
Right. And so for people wondering what is watchful waiting, there are, I'm just going to break it down simply. There are different approaches to helping people with gender dysphoria, or let's be clear here. And again, I'm trying to wade through all the confusion and all the misinformation. So in the old days, a child could be referred to a gender clinic not for dysphoria. The kid may have been perfectly happy, but for the parent's own anxiety or fears. So wait a second, my boy likes to wear dresses or he's very effeminate. So the kid was totally happy himself, but the parent brought the kid into the clinic, and again, the child was happy. Okay, but they were either they were included in these earlier studies, right? They didn't have gender dysphoria. They just had gender non-conforming behaviors. So whether it's for someone with gender dysphoria, whether they're actually extremely significantly clinically uncomfortable or dissatisfied in their body, okay, or their sense of identity, or it's just gender non-conforming behavior and the kid's perfectly fine, right? Watchful waiting, simply stated, say nothing, don't try to lead them one direction or the other, just validate and love them as who they are as a person, and just step back and let's see what happens, as they get older. That was watchful waiting, not leading them one direction or the other. And so, the far extreme practice would be conversion therapy, saying, no, you are a boy, you're not going to dress this way. Okay. And then there was something in between. And I do want to bring it up. Okay. Because again, I think it's really important for people to understand all the stuff behind the scenes, because all they're getting is distorted views on this. In Toronto, at what was the Clark Institute of Psychiatry, now is CAMH, Dr. Ken Zucker many years ago opened up what was only one of only two clinics in the entire world, the Gender Identity Disorder Clinic, and the other one was in the Netherlands. There were only two in the entire world.
Mm-hmm.
Dr. Zucker's a colleague. Dr. Zucker was clear, saying that it would be preferable for the child to remain their biological sex. Of course it is, in the sense of, pragmatically speaking, if you have a choice of either learning to be who you are comfortably in your body and not have to live literally the rest of your life under hormonal and or surgical treatments, because that's what it will require if you transition medically, right? Your entire life, which can interfere with your functioning, which will prevent you from having sexual response to some
Right.
degree, maybe never having an orgasm or becoming infertile. And again, just going through your entire life with this treatment. If you're able to avoid that
Mm-hmm.
and learn to live in your own body, of course that's preferable.
Right.
If
And
if
that's not
that's who you are.
denying, and I'll clarify, that's not to suggest, deny who you are, but looking at the pragmatic and practical aspects of major surgery.
Right. Either hormonal treatments, again, or actual surgery,
Yeah.
right? So that's what he was saying. That, of course, would be preferable. He was not making a moral judgment.
No.
Now, I can't read Dr. Zucker's mind, but I have communicated with him many times and I've seen his writings. And I have not seen anything that would make me think he was saying, no, these kids are bad. They must be boys if they're boys. So what I'm saying is, at that clinic, he did really push parents to make their children engage in gender typical, quote unquote, gender typical behaviors, clothing, hairstyle, and so on. right? So he did do that. But again, it was not with the intention to, it wasn't conversion therapy. He wasn't torturing these kids. Now, some people would say, well, it is torture. If the boy wants to play with a doll and you're saying, no, you can't play with that. No, is that torture? I think then now we're not using words properly. Okay?
Yeah.
Was it painful? For sure. Did some parents who were interviewed say it was like torture for them to deny their child what they want?
Sure.
To see their child go through this distress and not being able to be who they think they are? Right? I get that. But it wasn't done with malicious intent.
No.
So what I'm saying is there's actual conversion therapy. And then there was Dr. Zucker's approach, which I can understand why people think it's conversion therapy, but I have seen no evidence to say that it was conversion therapy.
Right.
And then there was watchful waiting, which was just saying, just back off, tell the child we love you, etc. But, do nothing, say nothing about the gender, just let the child be who they are.
Mm-hmm.
And then now we're at gender affirming care. And that's where the bait and switch happened. That's where that's where all the smoke and mirrors happen. I just want to really highlight this. And this will be one of the links that we present, because in the last couple of years, whether it's Jon Stewart or Rachel Levine or so many other people, they say the science is settled. Every single medical, psychiatric, psychological organization in North America says that gender affirming care is the way to go.
It's false.
The American Academy of Pediatrics, the Endocrinology Society, they all say that. And I just want people to understand how those decisions are made. And again, one of the links that we're going to send, I'll talk about in 2 seconds. Okay, but I just want to very quickly say, it's not like there's a vote. It's not like every single person within these organizations is given a bunch of literature, goes through a course and is educated, and that says, okay, let's agree. It's a tiny handful of people who are the experts within that organization who deal with this, most prolifically, and they talk with each other and they set the standards. And as with any system, these are human beings. So some people have louder voices than others. Some people are given more credence than others. Some bully and others just say, look, this is not worth my time. I see what's happening. I don't agree with it, but I'm being shut down. I'm being shunned. I'm done. Okay. So it's not like it's a hard science. It's done, we hope, properly and ethically, but we are human beings in the end, and we're trying to make these decisions. And so many of the decisions that have been made with regard to gender, and people admit it, it's for politically correct reasons. And anytime you're trying to reduce stigma, shame, pathologization of someone's experience, I'm all for it. But it can't be done at the expense of reality, okay, or best practices. So back to the gender affirming care. In the WPATH, which is the World Professional Association for Transgender Health, they came up with the standards of care 8 this year, or it was within this past year. Standard of care 7. Sorry, they came up with. Oh, I'm gonna get it wrong now. I'm pretty sure 8 just came out, and the other one 7 came out about 10 years ago. Okay, and in the previous edition, nowhere, if you do Command F and you go through the entire document, which I have, nowhere is the word watch or wait even mentioned. Watchful waiting is not mentioned. Okay, so it started there, but it was 2018. The American Academy of Pediatrics came out with a policy paper, and it explicitly stated that watchful waiting is outdated. It's not the best practice anymore. It is gender affirming care. And Dr. James Cantor on his site, Sexology Today, and we'll post the link. He went through their paper. He went through their claims. And by the way, in the same paper, it also talked about conversion therapy being harmful, for young people when it comes to their gender. Okay, and they had all these papers cited. And when Dr. Cantor analyzed all of the evidence that they provided, he pretty much showed that when they claim, for example, that affirming care, like this paper indicates that it's gender affirming care, that's the way to go. In fact, it was talking about watchful waiting. This is literal gaslighting.
Wow.
Okay.
Yeah.
So in a paper either it says, well, we can't say one way or the other, or it was talking about watchful waiting. The policy paper claims it's in support of gender affirming care, which is it's gaslighting. Like
it's
I said,
gaslighting. So, there's no other way to put it.
There's no other way to put it. It's because they assume that the public's not going to read through this paper. So again, if people want to go through it, Dr. Cantor, he published it in a journal afterward. It's all there.
Yeah.
So it was at that point, around 2018, was either 2000. I'm pretty sure it's 2018, not 17. It might have been the end of 2017. Again, if I'm off by a couple of months, I apologize. But when the paper came out, that was the major shift. So from there, Now, these people I mentioned earlier can say it's settled science, everybody agrees. And no, not everybody agrees. Because gender affirming care, if you're saying watchful waiting is not acceptable, we have to do gender affirming, then what exactly is your response? If a boy says, I am a girl, watchful waiting would say, okay, we love you. All right. And just, take a holistic approach. If you're doing gender affirming care, by the definition, oh, you're a girl? What pronouns would you like to use? Would you like to change your name? How would you like to dress? So you're already sending them on a pathway toward transitioning. You are helping them transition because you're affirming their gender. And the research is pretty clear. Sorry, the old research, just want to go with this, people understand this. The old research, when they looked at people who ended up going on puberty blockers or cross-sex hormones or had surgery, in the old days, the screening process was thorough. Okay. They made sure that these people, they ruled out all these other potential mental health issues.
As it
They
should
made sure
be.
these are as it should be. The research, was, again, if you read the papers, you see that they wanted to make sure that these are good candidates. So they had to screen out, unfortunately, not, sorry, I shouldn't say unfortunately. Fortunately, if it's not the right path, they screened out many, many people and they narrowed it down to the small selection of people. They say, you know what, we think they'd be good candidates. And that was happening, just up until a few years ago. Now, everyone basically, okay. And again, I'm not saying I'm not saying 5-year-old children are being medically transitioned. We'll talk more about that. Again, the misinformation there. Okay. But what I am saying is that the same practices that used to be in place to ensure that anyone going in this pathway is on the right pathway. And by the way, it doesn't guarantee that they're on the right pathway, but it makes it more likely. Okay. Those are no longer in place. And in fact, so many organizations are saying we shouldn't even have gatekeepers. How dare we question a child or a teen's sense of self? They know better than we do. So they are literally saying, get rid of the gatekeepers. Now, I understand gatekeeping. If the gatekeepers have bad agendas, if they say, we're not going to let anybody become gay or trans or whatever, I understand that. That has a bad
But
connotation.
extremes on any end are a problem.
Well, yes, either no, we're not going to let anybody go through this pathway, or let
everybody
everybody go
does.
through these extremes.
Yeah.
Exactly.
And
So again,
I was going to say the adults in the situation have the responsibility to, to be prudent and to be ethical and to, view this with the same careful eye that they would anything.
Exactly. And for any organization to say, get rid of the gatekeepers, and again, understanding, take out the negative connotation. If we're saying that person is simply the expert who is qualified, not on his or her own, but in collaboration with the individual, with the family, and so on. If these are the people who altogether make that decision, okay, but they're the ones who give the final approval, there's nothing wrong with that. Now, by the way, anyone who is familiar with WPATH or the standards of care will say the gate, that the document itself does talk about that. It does talk about collaboration, et cetera, et cetera. So they're talking out of both sides of their mouth, however, because in some places they say, no, proper evaluation and so on. And in others are saying, who should we be to be the gatekeepers? Okay. And by the way, I just want to throw one more thing in before we continue, just because I don't want to forget it.
Yeah.
When people say, and I'm not going to name names, but when famous psychologists and psychiatrists and doctors and advocates say, a person's gender is fluid. It can change at any time. Okay. If you're going to say that, if you're saying that, a person can go from boy to girl to both or to non-binary to whatever at any time throughout their lifetime, why would you then either push, encourage, or simply support the notion of transitioning them surgically or hormonally in one direction? It's not reversible. We'll talk about puberty blockers versus cross-sex hormones, okay? But when it comes to medical transitioning, you can try to reverse it, but the impact on the body, the impact on the psyche, the impact on your functioning, that's not reversible. That is there. So if you're saying that it could change at any given time, then why would we medically transition them?
Right.
And now you're locked into one pathway.
Right. Yeah. So
doesn't make sense.
I want to talk more about that blatant paradox, but I want to add in something about watchful waiting. In a less controversial topic, again, I'll use the analogy of ADHD. It is not uncommon for us at the clinic to have, let's say somebody who's under 6, because 6 is typically, the proper age to assess and diagnose. We will tell parents to wait and watch. And that doesn't mean, sit idly by. but it means, take note of their symptoms. Do they get better? Do they get worse? Because kids develop at a rapid rate when they're children. And, what is problematic 1 month may not be 3 months, 6 months down the road. So, in the same token, watchful waiting with respect to gender identity and everything we've spoken about here, it doesn't mean sit idly by and deny the reality, but watch, as a parent should do. Watch and be aware of what's happening. You don't have to jump the gun and do something drastic right away.
Right. And look, any kid what people are failing to understand is in the old days, there was no TikTok.
Yeah,
So a child going through, and on the one hand, the TikTok helps people know, oh, I'm not alone. There's others like me, which is great. I
it
want people
is.
to feel that feeling of isolation is so terrible, whether it's about gender or anxiety or depression, right? So it's good to have that sense of belonging in that way. But by the same token, when they're seeing on social media every single day, okay, you must get this, you must get this, it's going to save your life. If you don't get it, you will literally die.
Well, and
You're going to
how,
feel so distressed. You're
yeah,
going to have
boy, is that enticing. Like, oh, this distress can go away. I can feel better. Of course, somebody's going to want to do that.
right. So those kids, if the parents are saying, let's hold off, or the doctor saying, let's just wait and see, and so on, it's going to be more than ever before in the history of dealing with these issues. The child's going to say, no, no, no.
Hmm.
And they're going to push more saying,
Sure.
I need this. My life depends on it. And by the way, as the Littman study showed, and as the Diaz and Bailey's, I can't remember. I spoke because I've spoken with Suzanne Diaz, it's a pseudonym, but and so many other parents. The kids are given a script when they're, whether it's on TikTok or on these social media groups, right? They are literally given a word for word script on what to say, whether it's to get their chest bound, whether it's
Mm-hmm.
to have a double mastectomy,
Yeah.
whether it's to get hormones, word for word, and that's what
Yeah.
clinicians are saying. So again, none of this means that someone who says this is not really going through that. Some are, but others are being told what to say. And if you're told what to say and you say it over and over and over, you start to believe it.
For
Anyone who
sure.
denies that, especially like during these developmental stages,
Yeah.
like anyone who denies that process is denying reality again.
Yeah. Yeah. So let's go back to the paradox that you identified there, as far as I want to make sure that I articulate this as clearly as possible, that, there's gender is fluid, and we can, according to this notion that we can identify how we feel from day to day, and it changes and so on and so forth. And yet we're being so, or being suggested that we be so binary in, transitioning our body to match how we feel. Well, how does that work if it's changing from day to day? And not to mention, as far as pronouns, there's also, this putting people into a box with that as well. So it's incredibly confusing, as far as, on the one hand, we're hearing that, you are whoever you feel like, and you can identify however you feel like, but then that also reinforces this binary system of pronouns and of, the body matching the gender. And I'm choosing my words carefully here because I don't want to sound flippant, but it truly is
Right.
confusing.
Well, yes. And by the way, they would say, well, it's not necessarily a binary because if we use they or a term that doesn't exist in the English
Yeah.
language, then that goes against the binary. So it's not just a binary. They have all these different counter arguments to what you're saying, but none of them holds water if you look at them in their entirety,
Hmm.
right? Same with WPATH with their standards of care. In certain sections, it looks prudent. It talks about how the fact is we don't know before puberty whether a child is going to persist in these feelings and so on. So we need to be cautious. It says all that. But when you look at it in its entirety, it just doesn't, it's not consistent. It's not internally consistent, right? So again, going back to the gender affirming. So yes, and by the way, again, if there were no hormones or surgeries involved, it would still be, I think, chaotic in the child's life. If they say, well, today I'm a boy, tomorrow I'm a girl, another time I'm a they, other time, okay. If they said that, and that's just they're thinking about it, that would be confusing enough. But let's not forget that at the end of this path, no, sorry, not even at the end, 2 steps down this path, every one of these children, every single child who's seeing anything about gender, there's not one of them who has not seen, either through the people doing this or through what the people are saying, they have seen that surgery or hormones is the solution. And that's what people need to understand. If it was only about just talking about things, then I'd say we can contain it. But when they're saying, I need this, and by the way, again, this is what I want people to understand. This is where ideology comes in. This is where brainwashing and gaslighting comes in. When people are basically being told from a young age, and we're talking like 5 or younger, when they're being told things like, for example, well, you think you're a boy, but you could be a girl.
Hmm.
Okay, we're talking to 5-year-olds, 6-year-olds, right? There's never been any study to determine what impact hearing those things constantly has on a young child's developing sense of gender and
Yeah.
identity and self. Okay. Never in the history of humanity have kids en masse being told that. And if people say no, no one's saying this, yes, they
Yes,
are.
they are. And
People
we
are being
know
recorded
that,
saying this. Lawsuits are being filed.
yeah. And in other contexts, we know the importance of consistency and stability when it comes to children developing their sense of self and their identity and so on. So I imagine it is incredibly confusing to hear that, because what are they anchoring onto then?
Right, exactly. And again, it's and there was I was going with that about the whole identity, about the gender. Well, yes. So here's the part I was getting to. Part of the narrative now. And by the way, again, I'm sorry I start and stop, but because there's so much to talk about,
Yeah.
and I just think about all the things I've heard people come to me saying, and confused and lost and angry, um, that the language is so subtly or sometimes abruptly shifting, and so is the goal. So every good person, if someone says, "Hey, we want to support trans people, we want to support young people who have dysphoria or confusion or distress and so on," who would say, "No, I don't want to do that"? So everyone says, "Of course, tell me what I can do." Well, just do ABC. Okay, no problem. But when ABC becomes now, LMNOP, it's scary. So the shift now is, okay, let's talk about, gender identity and so on to young children, which again is questionable. Okay. But here's the thing. When children are now hearing, and they are hearing this, that puberty is a traumatic experience,
Oh,
not just for people
geez.
with gender
Wow.
dysphoria, but for everybody. When they're saying, why are we letting children, if you don't believe me, go on a TikTok. This is what they're hearing. Why are we letting all these kids go through the trauma of puberty? Why don't we suppress everybody's puberty? Okay, now, no
You're
credible
kidding.
doctor would
I've
say
never
this, we
heard
hope.
this. My gosh.
Oh, oh my goodness. Oh yeah, yeah. Okay. And again, I don't know if I've heard any doctors say this, although I've heard some doctors come pretty close, right? But these influencers, who are kids going to listen to? A doctor
Wow.
or an influencer?
Yeah.
These influencers are talking about the trauma of puberty. Now, for someone who has gender dysphoria, if they're a child and they feel that they are in the wrong body, or it doesn't match, or they feel uncomfortable, they can't live up to the societal expectations, or they physically feel so uncomfortable in this body, puberty can be or is a traumatic experience for them.
And
But
let's
that's for a tiny,
Yeah,
you know,
and
it,
we can't call something that is difficult and uncomfortable traumatic. Again, words have meaning, and perhaps for some, like you're saying, as a small percentage of the population may have a number of factors that do actually indeed make it traumatic. But the vast majority, it's difficult, it's trying, it can be distressing. It's not trauma. That is not trauma.
exactly. And again, words matter. So if a child hears from a young age, that's what they're going to believe. So now they're feeling uncomfortable. Now they're getting attention that they didn't get before. Now they are processing it as a traumatic experience. And
Yeah,
if they're processing it that way, guess what?
yeah,
They'll experience it that way
absolutely.
as trauma.
Yeah,
Right? So we're destabilizing them. So yes, this whole idea about puberty being this terrible thing, it's part of the damn human condition. It's part of every
yeah,
mammalian
yeah,
species.
yeah.
We go through this. This is how you grow up. So, and by the way, so if I can just shift gears a little bit, if you don't mind, because
Of
I think
course.
it's just related to it. Because
Yeah.
again, misinformation. So people are conflating. I talked about several conflations. One of the conflations that people make, usually on, let's say, the anti-trans side. And when I say anti-trans, I'm not saying they're transphobic. I'm not even saying they're hateful. I'm just saying that they have concern. Let's say they're gender critical, the gender critical side, where they're saying we want to fight back against the gender ideology. So responsible, well-informed, reasonable people on that side aren't saying what I'm about to say. But many others are taking that extreme position, which is they are saying that we're trying to sterilize young children, like, 5 years old, we're
Mhm.
giving them, hormones. There are two types of, generally speaking, there's two types, and people should understand this. There's the puberty blockers or puberty or hormone suppressors. And then there's the cross-sex hormones. Now, speaking about language, as you know, in the DSM-5 text revision, we're not supposed to say cross-sex hormones.
Yeah.
We have to say gender-affirming hormones. Okay, the language has changed for purely political reasons, right? By definition, it's a cross-sex hormone. Okay, because biologically, if you are a male and you are having your testosterone suppressed and you're having your estrogen raised beyond what your normal body would or what your body would produce normally, that's a cross-sex hormone.
Yeah.
So that I'm going to use the proper terminology. It's a cross-sex hormone. So for people to understand, the puberty blockers, the hormone suppressors, most typically Lupron, that's what's given first. Now, the people are correct that it is used for chemical castration, right? Because for males, it suppresses their testosterone production. So yes, it is chemical castration by definition. And yes, it's used for certain forms of cancer. And yes, using it to suppress a kid's puberty is off-label. Yes, it is. And then people say, but wait a second. What about all these parents, millions of parents whose kids have precocious puberty, whose child is going through puberty too quickly? And so the parent chooses, through the doctor, consulting with the doctor, to slow down the child's puberty development. Well, if someone does not see the bait and switch here, if they can't understand the difference, I'm going to explain it out. I don't know how you don't see it, but I've heard many people, including doctors who should know better, sound like they don't understand the difference. In the case of a child with precocious puberty, something is happening with their internal organs, okay? Whether the hypothalamus, the pituitary gland, whatever's happening in their endocrine system, it's not how it's supposed to go. And it's having a negative impact on the child. In some cases, a little bit, in some cases, a lot. So when you use a treatment to help remedy dysfunctioning or not optimally functioning organs, that's very different from using the same chemicals on healthy organs. A child who's transgender or who believes that they're trans, or who's going to have their puberty blocked or suppressed, their hormones suppressed, their organs are functioning properly, right? So we're giving, and it's the same as saying giving antidepressants to somebody who's truly depressed can help with the depression. Giving antidepressants to people who are not truly depressed, it has an impact on their brain, right? And same with, and I'll just give one more example that people can really understand because it happened with my father. When my father's spine collapsed, it literally collapsed. He was given enough narcotics that it scared the hell out of his doctor. His doctor said, "What are these doctors doing? It's going to kill him." And the doctors laughed and they said, that they say all family doctors say that because a body that's going through so much pain can absorb these narcotics at a level that would kill someone who's not going through that pain, right? Someone who just wants to do it recreationally, if they took that level, it would kill them because the brain and body is functioning differently. So it's the same with puberty or with puberty blockers. So that's number one. And even we know, and here's the thing. So I want to get to cross-sex hormones in a second, but with puberty blockers, the fact is they do have side effects. Now, some of them are worse than others. Most of them, it has to do with bone density, they can develop osteoporosis as they get older, and they claim, well, if afterwards, if we just pump up the hormones that we suppressed or let it go back to normal, it remedies. It goes back to normal. Okay, in some cases, yes. In other cases, no. There are a number of different physiological impacts of these puberty blockers.
Yeah.
Right? They're not harmless.
It's not a light switch. It's not
kids,
you take it and then you don't take it and everything goes back to normal. Absolutely not.
Exactly, but it's sold as a pause. Like, it's just a simple pause, and it's totally reversible. Now, here's the thing. Again, look it up. It was 2019, I believe. In the UK, the National Health Services, the NHS, which ran the only gender clinic, the Tavistock Clinic at the time, okay, they, on their website, they had this, puberty blockers are totally safe, harmless, reversible, completely reversible. They took that off the website silently a few years ago. Now they were being sued. And so so how many parents, how many kids saw that harmless, reversible, safe, pretty casual, and they went on that pathway believing the false information they were given.
And sadly, rightfully so, because, the public is to trust healthcare providers to be doing things ethically, properly, and presenting things as they are.
Exactly. So if you're a parent whose child is going through all this distress and everything, and you're told, oh, there's a safe thing, it's just a simple pause, whatever, a good parent wants to help their child. And if they're being told by the doctors and everyone around them, this is going to help them, then I wouldn't begrudge them for thinking that this is the right pathway. But again, in Europe, and people, especially in the States and Canada, they're saying, they're saying that it's only hateful people who are asking for more research, asking for a moratorium on using these treatments or treatments, right? When you point to Europe, okay, Europe is traditionally much more liberal, especially in the Netherlands, than we are in North America. Well, Canada now is really, really liberal, but in the States, right? Europe is far more open-minded.
Yeah.
They're years ahead. And that's why they realized we've been doing something that doesn't have proper backing. All the research, there have been meta-analytic reviews when they look at the research that claims that hormone suppressors or cross-sex hormones help the people with their mood, with their quality of life, with their suicidal ideation or attempts. Okay, when you look at the research, the vast majority, if not all of it, is either extremely poor or poor. Okay, I saw one study that said that there was one high quality study done. Okay, one that made these claims. And if you look at the studies, yes, it might help here or here, but it doesn't help in all these other metrics, right? So when people claim that this is the way to go, that gender affirming care, remember, it's not just saying, yes, you're a boy or yes, you're a girl. It's now we're also going to, when you get older, we're going to transition you medically, right? The science behind it is not established. It's truly not. And if you're going to do this experimentation on younger people, right? Ethically, I think you're violating your principles.
Absolutely.
And by the way, so I just want to go right. So I want to throw these things at everyone, and feel free to interrupt me anytime, Hallie, if I get off track. Okay. But so the first step is hormone suppression, and then the pause after 1 year, 2 years, 3 years, 5 years. Then they might go on to cross-sex hormone. And the research shows 98 to 100% of people who go on the puberty blockers will go on to cross-sex hormone. So people would say, okay, well, that proves that they're on the right path, right? They started puberty blockers. They took a pause, they checked, and they realized, you know what? Yeah, I really am the opposite gender, or opposite sex. So I'm going to go on to cross-sex hormones. Thank goodness I did it. And okay. Or the alternative is back to cognitive dissonance. If you've been told your entire life, or for years of your life, this is the cure, and then you start taking it. At first, by the way, many people do have that feeling like, oh, it's like I'm finally, whether it's placebo or real, they're feeling like, yeah, I feel better, right? Of course, at the beginning, that honeymoon phase. But psychologically, once again, if you're telling everybody, if you're, let's say you're a biological male and you're telling them, I'm a girl, I'm a girl, I'm a girl, how do you turn around later on and say, well, I know I've taken all these cross-sex these puberty blockers. I know I've lived as a girl for several years. I know I've told everybody I'm a girl, and I've asked you to use these pronouns or this name and whatever. How do you then go back and say, whoops, I made a mistake?
Right.
So I'm not saying that they're lying to others.
No.
But cognitive dissonance reduction, we know, which is a very powerful phenomenon, will make people process and interpret their experience in such a way that they will say, yes, this is right for me. Okay?
Right. And I'm going to add in here, because I can, again, see what you're saying being taken out of context. We are not suggesting by any means that there aren't people who truly benefit from this, right? So people who are truly transgendered, truly dealing with gender dysphoria, and this gives them that relief that they were looking for. And, wow, finally I can be who I am. That absolutely does happen. But what we're talking about is the high number of individuals who are being proposed this treatment when it's not the right fit. It's not the right solution.
Right. And again, in those studies where it showed that some people did get benefits, and most of them, they don't have control groups, which is important. Okay. Because how do we know that they got better because of the medication?
Yeah.
Maybe they got better because of the passage of time. Maybe they got better because now they are doing therapy. Maybe they're because of acceptance and people are hearing them and everything. And maybe they would have reached the same level of reduced depression or anxiety or increased quality of life or reduced suicidal thoughts or behaviors without the hormone, without a control group. You can't say that. Okay.
Yeah.
So, but having said all that, I have, at least anecdotally, I have spoken with a number of people who say, yes, it saved my life, maybe metaphorically or literally. So just like to your point, again, anyone who misunderstands is intentionally doing so. Right. I will say it now, I've said it many times, and a lot of people who like what I have to say about all these things don't like it when I say this part, but I'm going to say it. The fact is, I just want to reiterate what Melanie said. I have absolutely no doubt that there is a tiny percentage of people who truly do benefit from hormonal and or surgical interventions to help with their gender dysphoria, and all the power to them. And I want them to get that help.
Mm.
They benefit. Problem is, when I say this, I'm not talking about kids or teens. I'm talking about adults. I'm talking about people who have the full capacity to make fully informed consent. And people have to understand. And I want to go back to the whole puberty blocker, cross-sex hormones in a second, because I want to blow people's minds in a second, okay? But I want people to understand that there's not one credible doctor, psychologist, psychiatrist, whoever, who will say, or who will not say this, which is, we do not know with certainty which kids prior to puberty will persist in their feeling of cross-sex, or cross-gender identity. Okay, so if a child, say if a boy is 5, 8, 10 years old and says that he's a girl, until he goes through puberty, we do not know whether he really, really feels that way and will persist in feeling that way. It's puberty that seems to be, and research shows this. It's when you go through puberty, that's when we get a better sense of what this child really, like who they are, because that's when your body's going through the changes. That's when your sexuality is developing. And that's when you have a better, more gestalt sense of who you are. Okay. So anyone who ever tries to prevent a child from going through puberty, you are preventing them from being able, or we're preventing people, we are preventing ourselves from being able to determine whether this person is on the right path or not. Right. And
Yeah.
yet that's what they're trying to do. They're trying to get in earlier and earlier to prevent puberty from either happening, or at the second Tanner stage 2, right at the very beginning of observable changes, that's when they want to get in right then and there. Okay, that's not going through puberty, right? The whole idea is not to go through puberty. So we are not allowing the kids to go through the natural process that will weed out so many of these people. So then how can we say that we're doing the right job
Yeah.
if we don't allow them to go through the process to see
Right.
whether they truly they feel trans still afterwards?
And not to mention, the back to what we started with as far as the social construct of gender, there is some validity in some context to that as far as gender norms, right? So I'm observing here what's happening is that a child is, gender non-conforming, and this is one of the criteria in the DSM to look for. Um, but that in and of itself isn't sufficient. But oftentimes, now I'll say, parents or influencers online, for example, are taking that as the be all and end all. Well, they are gender nonconforming. Therefore, they must be transgender. But there's so much uh, social context to what that is and what that looks like and what that means. It's not the be all and end all by any means.
No, and once again, the whole idea about the distress. If a child never saw TikTok or anything like that, and again, it's a boy who's just gender, I'm just going to say boy, gender non-conforming. So he's very effeminate, likes to play with dolls, likes to play with
Right.
girls and everything like that. He would not feel any distress. The only distress he might feel is if he's being socially excluded
Sure.
or ridiculed or
Yep.
bullied, right? Or rejected by his family. Okay. That would be the distress. But if he's just like, oh, I'm just, very effeminate, that's one thing. And we know, statistically speaking, there's a huge chance that he'll just turn out to be gay.
Yep.
Nothing wrong with that. Okay. But if he's seeing the social media, and again, he's being told that you must be like this or you must be like that. If you don't get help, you're going to, that child's going to articulate
Mm-hmm.
the kind of words that would make you think he's distressed when really he
Right.
wasn't before. So
Right.
there's going to be a greater impetus to say, no, we must help him because he's suffering. And here's the thing. Older studies, and again, I just want people to understand this. Older studies did have, as I said earlier, not kids who were, dysphoric, but rather just gender non-conforming. And so there's a bit of conflation there between trans kids and, or supposed trans kids who identify as the opposite sex, and gender non-conforming. Well, here's the thing. Again, like I say, if we come in too quickly, if we take these children's words, just if we don't question the words, we just say, well, the kid says one thing or the other. He knows he's not non-binary. He knows he's transgender because he's 5 years old. He said it. If we take him at his word, and then we say, we should affirm his gender, which is that's suppresses puberty as soon as it starts or even before. Okay?
Mm-hmm.
All right, that's of course that's bad practice, right?
Yeah.
That's terrible. But the fact is, if we had just done the watchful waiting, we would have seen that up to 94% of those kids, up to 94%. Now, some say 98%, but even in WPATH's own standards of care, the previous version, okay, they even cited that up to 94% of kids, if you say nothing, they will say, no, I am a boy. I'm not a girl. Like if
Right.
they're a biological boy, right? Up to 94%. The most conservative number, the most conservative, and it's not a credible number, but we're just saying, let's just be the most conservative. 54% will say no, they'll desist. They'll say, no, I'm not trans.
Mm-hmm.
Okay. That's the most conservative. If you take a look at all the few studies, and there's about a dozen, there's not that many, but actually proper follow-up care, okay, for years and years. Usually we're hitting about 80%. Now, all these numbers are being tossed around, okay? So I'm saying the reason 94% is there is because it includes gender non-conforming kids
Mm-hmm.
who never had a problem in the first place, okay?
Yeah.
But if we weed them out, it's minimum 54%. But that's a really, really low estimate. James Cantor on his site talks about this. Again, we'll send the links, okay? But on average, and Dr. Ken Zucker recently did an analysis, and it's about 80%, okay? So again, think about that. Anybody who's pushing kids, whether it's hormonally or socially, there's a huge chance that you're making these kids believe that they are something that they're not.
Yeah.
And you're making them believe that they need a treatment that is going to, in fact, do more damage than good. Because again, 80 to 94% or whatever, they don't need it.
Yeah, and I've read actually to that point that there is some homophobic undertone to some of this pushing
Right.
of trans ideology, insofar as, like you mentioned earlier, for example, and we're picking on boys here, but let's say a boy who is more effeminate and has gravitates towards more girl toys and clothing and so on and so forth. Um, that's being pushed that, well, then you must be a girl, where in reality, they could actually, and likely are, statistically speaking, homosexual. But it's almost like this homophobic uh, undertone is happening here, as far as, well, no, you're not gay, you're trans, and you're actually a hetero trans person. It's very confusing for people. We hope this episode has helped you think more critically about the topics discussed, but please email us at the email address in the description if you have questions. Join us next time for the continuation of this topic.